Hello everybody, I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a master class in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January. Hello everybody, I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a master class in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January. Hello everybody, I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a masterclass in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January. Hello everybody, I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a masterclass in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January. everybody. I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a masterclass in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January. Hello everybody, I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a masterclass in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January. everybody. I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a masterclass in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January. Hello everybody, I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a masterclass in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January. everybody. I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a master class in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January. Hello everybody, I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a master class in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January. everybody. I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a master class in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. J.C. Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him on whichever aspect of cardiology. And then ISE's commitment to teaching cardiopulmonary resuscitation across the medical profession as well as to the lay persons. As a part of this commitment, we have an enthusiastic speaker from Jamshedpur in form of Dr. Mandar Shah, an interventional cardiologist. He has run a lot of CPR teaching programs in Jamshedpur, and he will tell you or teach you all about CPR hands-on, how you would as a bystander come in and you may be able to save a life. This is very important. This is an important part of the program, so be there till the end. This is going to be a very interesting program. I invite you all, as also let this invitation pass on to the fraternity, the medical fraternity around you. I'm sure they would be benefited by attending this program. Thank you and see you on 12th January.
Okay, good morning, everybody. I'm Dr. Ashish Nabar.
Recording in progress.
We'll start now. So, good morning, everybody. I'm Dr. Ashish Nabar from Mumbai, cardiac electrophysiologist, and I'm also the treasurer of the Indian Society of Electrocardiology. Under the secretaryship of Dr. Ketan Mehta, we have had a very active weekends through the year, planned with different collaborators, and the whole purpose is to deal with ECG teaching. That is the motto of the Indian Society of Electrocardiology, and it's a very popular series that gets attended by a lot of physicians, maybe some cardiologists, and I think it works out to be a great academic activity. So this particular academic activity is in collaboration with Merck, and it is very nicely labeled as CAD-A-THON. And the purpose here is to discuss ECGs in relation to coronary artery disease. So I understand from the sponsors that this is the fourth session that we are having in the CAD-A-THON. And to introduce this session particularly, we will have three presentations. So the first one, so I'm going to double up as a moderator as well as the first speaker. And the first session is going to deal with ECG in ACS, mainly concentrating on the tachyarrhythmias or arrhythmias in general, I would say, rather than tachyarrhythmias. This is going to be about a 30-minute session, but I'm okay, and I guess the other speakers will be okay if they find 20 minutes also good enough. Sunday, we may not necessarily hold people for too long. Keep a very focused presentation. I have an interesting faculty joining me. Most importantly, Professor J.C. Mohan. He needs no introduction actually and truly to the Indian diaspora in the and the Indian community attending these academic cardiology seminars is because since the time I was a resident, Professor Mohan was the professor of cardiology at GB Pant, and we have always liked to listen to his discourses on various aspects of cardiology, maybe it echocardiography, interventional cardiology, ECG, And I'm sure he has, after so many years, continues to have a lot to offer in terms of teaching some or the other aspect of cardiology. Today is going to concentrate on beta blockers, a very age-old drug which has been reinvented a number of times, repurposed in number of times. Syndications have just kept widening. And what is the contemporary value of beta blockers in the coronary artery disease setting is what he will focus on. And then there is a lot of need to understand what sudden cardiac arrest is, how to avoid a sudden cardiac death, what role a bystander, whether he's a medical person or a lay bystander, what role he can play in salvaging this under-recognized entity called sudden cardiac arrest, which leads eventually to sudden cardiac death, unfortunately, most of the times. And if you happen to be a witnessing bystander, there is a lot you can offer in terms of CPR, cardiopulmonary resuscitation, provided you are trained for it. And there is a big movement already in process. That big movement does appear a drop in the ocean at this point in time, but I'm sure we'll reach a threshold value educating not even the medical fraternity for that matter, but also the community to understand what CPR is. And for that, we have a very enthusiastic interventional cardiologist, Dr. Mandar Shah, originally from Bombay, now settled in Jamshedpur. He does a lot of CPR activities there in his free time and therefore educates the bystanders on how to do a CPR. He's a practicing interventional cardiologist and head of the or director of cardiology at the Tata Main Hospital in Jamshedpur. So a very, very learned faculty and a very, very contemporary topics to deal with. So I think these are the, well, not so few words I had to say before we get on with the first presentation. So is that okay that we start with the first presentation?
Ashish, for a moment,
Yeah.
I was given to understand that my job will be moderation. Am I speaking on anything?
Oh, yes. I think beta blockers, cardioselective beta blockers, what was in planning.
Oh,
So
I was never informed about that.
So, Dr. Mohan, beta blockers for you is a child's play.
Yeah,
So,
so what I'll do is that let me quickly rearrange the slides somewhere
yes,
and
yes,
get back to you.
yeah,
Meanwhile, we can get going with this
yes.
thing.
So there is
But
enough time. Yeah,
I would be off for maybe 5 minutes and then rearrange the slides.
that is perfectly fine. Please take your time. So I think let's get on with this interesting session. And the first presentation is by me, and I'll deal with some arrhythmias in the acute coronary syndrome. So let's get on. So as I already said, I have to double up as a moderator as well as a speaker, and I have already introduced the two co-faculty who will bring the other two topics to light. So this is the program. I think we already said a couple of things about this, and let's get on. So now arrhythmias in ACS is what I'm supposed to be dealing with is with the three well common, not so common things that happen in an acute coronary syndrome in an ICU setting and sometimes even before admission to the ICU. So we are going to deal with ventricular arrhythmias, and as you know, they can be polymorphic VT or sustained monomorphic VT, and how different they are even in an ACS situation in terms of recognizing, in terms of treating is what we'll talk about. Atrial fibrillation is a real nuisance, and we'll see what we can do with atrial fibrillation, how measured way we can approach atrial fibrillation in ACS. An AV block, though these times a little uncommon, but still sometimes does happen, and we'll discuss what issues surround the AV block in acute coronary syndrome. So here is a very important topic. The practicalities will be discussed with Dr. Mandar Shah, but what sudden cardiac death or sudden cardiac arrest is, it's a natural death which happens within 1 hour of the onset of acute symptoms. So the most important aspect of this is that it is unexpected. So somebody who was not known to be suffering or not known to be ill suddenly has probably a syncope or a loss of consciousness and does not wake up within an hour's time, he deteriorates and you have a death on hand in 1 hour, a very in the natural circumstances, that is sudden cardiac arrest. So sudden cardiac arrest is many times under recognized, not appropriately certified, and we are not prepared to deal with it as a community, even as a medical community, and therefore this happens in a pre-hospital stage, and we must talk something about it. So what is the malady of sudden cardiac arrest? The biggest malady is that it doesn't get recognized. So there is no resuscitation attempt at all possible, because it may happen in sleep. So for all the good reasons, there is no possibility. Or it may be happening in a crowd where obviously a doctor is not there, but even the bystanders do not know what to do, and they do all sorts of things like breaking an onion and making people smell or whatever, and that's all obviously rubbish. Sometimes there is a lay bystander who manages to do some kind of a CPR. We do not have a defibrillator, so you never get the patient to the conscious level, so no raw return of spontaneous circulation. That so these two things actually occupy a lot of syndrome of sudden cardiac death, and there are few who you will be able to resuscitate, but unfortunately the delay would either result in cardiac, neurological, or other complications, or they may eventually still not make it and die in the ICU. And therefore optimal recovery, if you see that pie, that is a very, very small pie. So you very few people actually manage to go home in a good shape from a sudden cardiac arrest, but that doesn't mean that that should undermine our efforts to learn CPR and do the best we can and enhance the possibilities over time in terms of what best we can. Going to the mechanism of a sudden cardiac arrest, I think one needs to realize that if you have a ventricular arrhythmia, as you can see on this slide, a polymorphic VT degenerating into a VF and ultimately a asystole. So if you react from this time of starting of a ventricular arrhythmia till a asystole, if you can shock, you have a better chance of pulling this patient out, and that can be called as an aborted sudden cardiac arrest. But if a sudden cardiac arrest starts with the asystole, then the prognosis is worse. There is not much you will be able to do by a CPR. So this is the difference. If most of the times it is the ventricular arrhythmia that is causing sudden cardiac arrest, and you have a window of hope what you can do. Now, why am I discussing this in an ACS ECG talk is because ACS is the most common cause of out-of-hospital sudden cardiac arrest. This is the ECG recorded from a survivor immediately, and you can see that there is an acute ventrival MI with severe ST elevation, more than half of the tallness of the R wave, and therefore there is a severe ischemia here. In the angiogram that was immediately done, you can see that the LAD is occluded, and therefore this patient obviously had to undergo an emergency angioplasty to the LAD and could be salvaged. So ACS take home is the most common cause of out of hospital cardiac arrest. And therefore, what comes or what should come as a natural thing is to record a 12 lead ECG after the return of spontaneous circulation in a patient who has a sudden cardiac arrest. If you document a ST elevation MI, urgent CAG, and a angioplasty in an angioplasty enabled center is the way to go. Many times you may not be landing up, or the patient may not be landing up in an angioplasty enabled center, then at least it is thrombolysis when you record a ST elevation MI. As opposed to that, if you record a ECG and there is a suggestion of a non-ST elevation MI, one could take either of the approach depending on the condition of the patient. At times, you might have to be invasive, do angiography, and even stent a non-STEMI lesion, a possible culprit lesion, so as to salvage the situation. Or in a non-PCI enabled center, one may want to stabilize the patient conservatively and then decide what to do. So remember, there are these kind of approaches following a CPR and return of spontaneous circulation. Does that mean that the moment you resuscitate a sudden cardiac arrest victim, that you do CAG for all? Possibly, definitely, as I said, this is a repetition that if you have an ST elevation MI on the ECG that is recorded after the resuscitation, then doing a CAG and planning a culprit vessel PCI improves the survival to hospital discharge. So they survive better and they have a favorable neurological outcome. So STEMI should get a CAG and a culprit vessel angioplasty. In a non-STEMI, you may delay that, or you may plan an angiography when there is one more reason to do that after the CPR, for successful CPR. That is, the patient is hemodynamically unstable or there are repeated ventricular arrhythmias recurring. In that case, you may then intervene early and do a CAG and possibly a culprit vessel angioplasty. So there is a little difference depending on what you find on the ECG after the resuscitation, whether there is a STEMI or a non-STEMI. And as I told you, ACS is a very, very common cause of sudden cardiac arrest. Now, here is a patient who post resuscitation has an ST depression. Now, there is ST depression all over, and this is a very classic ECG with ST elevation in AVR. Now, this means that you are going to find a lesion in the left main coronary artery. And luckily, if a person with LMCA MI survives, then again, he would be deservedly getting an angioplasty, a left main angioplasty. So therefore, ST depression in this setting is not an unstable angina, but actually a left main related MI. So switching gears here from what you find after a successful thrombolysis or after a successful angioplasty or primary angioplasty, if you can look in the rhythm strip, you can see at least 3 sinus beats, and there is this rhythm which is where there is no preceding P wave. There's a little widening of the QRS, and the rate is just about touching 100. Now, this is an accelerated idioventricular rhythm. All of us have probably heard of this right from our undergraduate days, that you see it in an acute STEMI setting after a successful thrombolysis. How do we deal with it? Now, certain facts to know is that after restoration of the after thrombolizing successfully or after doing a successful culprit vessel PCI, about 4 to 5% of STEMI patients have a idioventricular rhythm, and there is no real suppression required by using antiarrhythmic drugs. Many times it happens in patients who have presented late in a higher clip class and who have inferior wall STEMI. So these are commonly the patients, and we do not really understand whether idioventricular rhythm is a good thing or whether in the long term it is a problematic thing. Problem is, if you get your arrhythmias post 48 hours in an acute coronary syndrome or in a STEMI setting. So all of you understand, by definition, if you get ventricular arrhythmias in the first 48 hours, it is still labeled as a primary ventricular arrhythmia, which is supposed to be not at a risk of recurrence. But if you get ventricular arrhythmias in the hospital stay after 48 hours of ACS pre-discharge, then if that is something that needs a little closer interpretation. This happens uncommonly, about 5%, and more common in STEMI patients than in unSTEMI patients. More common where your primary PCI was not unsuccessful, the restoration of TIMI flow was not great, and these people probably have an increased hospital mortality. So therefore, this peculiar subset needs to be analyzed from 48 hours after an MI to discharge. If you get ventricular arrhythmias, you need to analyze. Many times in the monitor, the ICU doctor calls you and says, I see this non-sustained runs of ventricular arrhythmia. Patient is about fourth day or third or fourth day after the PCI or thrombolysis, and how to react to it. Now, certainly, if it is a sustained arrhythmia, you will shock the patient out of it, and that's the best way to react. And if it happens repeatedly, even if there is no angina, you might, and this patient has undergone a thrombolysis, you might take him up for a rescue PCI, again do an angiography, see whether if he has undergone a PCI, you see whether the stent has been occluded or there is an acute stent thrombus something, and do a rescue PCI. So this is something, a recurring ventricular arrhythmia might warrant you to think again if there is an active ischemia happening. Sometimes it may be that the other non-culprit vessels may be having a critical stenosis and they may be responsible, and revascularizing them may help to settle the ventricular arrhythmia. So it is a concern when you, and it is a little debatable, and it varies how you handle a ventricular arrhythmia after 48 hours till discharge, depending on whether it happens once or whether it recurs. But it prolongs the hospital stay, and you have to suspect a worse hospital prognosis. And therefore, these are the number of things that we said happens many times when the presentation is late, when there is recurrent ischemia because of stent thrombosis or reocclusion of the vessel, when the untreated other coronary vessels have a critical lesion, And sometimes it is as simple as that the intensivist just refuses to take the inotrope dose down, or stop the inotropes, and they then serve as a kind of a stimulant, a sympathetic stimulant on this injured myocardium. So one has to analyze what is causing the ventricular arrhythmia and recur. There is obviously a moratorium period till 1.5 to 2 months before you think that this patient is a candidate for ICD. But again, this needs to be discussed. We might discuss it later, but we need to understand that this 48 to 1 till discharge ventricular arrhythmia scenario is something that will require individualization of your approach. Having sustained monomorphic VT is normally supposed to be uncommon in an ACS setting because acute ischemia usually needs to polymorphic VT, but you may land up with a sustained monomorphic VT in the setting of acute ischemia, and that is usually in these times. So, how to go about this? Most important thing is that you may have to retreat an ischemia. So, other non-culprit vessels or occluded stent or a reocclusion of a thrombolysis, you may have to handle ischemia. This is where I think Dr. Mohan will stress on increasing or amplifying the use of the beta blockers that are already on, escalate the dose, treat the electrolytes. Statin therapy, 80 milligram atorvastatin would be a good thing to do. And VT would probably need to be shocked out, and then an amiodarone would have to be given. Everybody knows lignocaine can be used in ACS much more often than we do in a late VT. So these two drugs have to be used. Amiodarone actually is more effective than lignocaine. Sometimes you have to combine the two, and a ranolazine probably has some borderline benefit. But sometimes this monomorphic VT keeps recurring, and you have probably had more than 3 episodes in 24 hours, and this is what we call as a VT storm. A recurring VT in this setting is called as a VT storm. Your options are the following. You may have to defibrillate, but sometimes when the patient is hemodynamically unstable, you have no option, and you may have defibrillate in a day 25 times but it's hemodynamically unstable situation, so you have no go. Sometimes there is an underlying bradycardia with the already existing use of your antiarrhythmics with QT prolongation. In such situations, you may have to, particularly if it's a polymorphic VT, you may have to continuously pace, or if the slow VT is recurring, you may have to overdrive, pace, terminate the VT. So in effect, you may need to get a pacing wire in. Amiodarone infusion is going on, but if you get a VT recurrence, you can try and control it by infusing a 150 milligram bolus immediately to stop that particular acute episode. Remember, people sometimes do not get this or do not know this. And then if it's a recurring VT, blocking the sympathetic tone is the biggest help, and this is achieved by sedating and ventilating the patient. There are other things that we said is handling the ischemia. Of course, re-angioplasty is one thing, but putting a balloon pump also improves the diastolic perfusion, and reducing the inotropes is something that I keep writing all the time when I attend these calls. And whenever it is possible to manage hemodynamics with the least dose of inotropes, that is something that is desirable. So these are a couple of ventricular arrhythmia situations that I had to discuss with you in the ACS setting. But there are also atrial arrhythmias that are a source of bother in a patient with ACS. And atrial fibrillation is probably the biggest nuisance that we have. Now, once again, it happens to a good extent depending on the condition of the patient. So I put it here as 2% to 20%. That is a wide range. But AF can be, one has to discriminate whether this atrial fibrillation that you see in a patient with ACS, whether it is pre-existing or whether it's new onset. Why you need to make this difference is because many times in pre-existing AF, you might initially do rate control and then eventually think of getting into sinus rhythm when possible, because in a pre-existing AF you have the situation of not adequately anticoagulated, not much of hemodynamic deterioration. Now there you may not be so aggressive to get sinus rhythm. Whereas if you have a new onset AF, then sometimes it deteriorates the situation much more than in sinus rhythm, and it makes sense also to get him into sinus rhythm because the chance of maintaining sinus rhythm is much better in this new onset kind of AF in ACS. So the number of mechanisms that you have to handle, most important, get the electrolytes right, treat the failure adequately, and sometimes sympathetic blockade or reducing the the inotropes may also help to, revert the AF or control the rate better. Who are the patient? This patient who gets the AF in ICU is generally a bad subset of ACS. Why bad subset? Because he came with a failure, because he had extreme LV systolic dysfunction following a large MI. Sometimes they have coexisting AF related factors like hypertension, diabetes, and then sometimes your angioplasty has not been so great with a lot of still the TB flow being not excellent. So, inadequate or insufficient result of the primary angioplasty. So, this patient who gets AF, remember, is a bad patient to have, because not only is it a nuisance to prolong the hospital stay, but it also leads to more use of inotropes, and that just makes the circle more vicious. More inotrope use, more chance of increasing the rate of the atrial fibrillation, more chance of not maintaining the sinus rhythm even if you manage to cardiovert. So this becomes a little dicey scenario. And though AF is not directly linked to mortality like a ventricular arrhythmia, but it is a marker or it's a epiphenomena of a bad patient subset. So how you deal with AF actually depends, as I said, a couple of things: how old the AF is, whether it's a recent onset, and then you have to look carefully because there are a number of things that you can target when you're treating a AF. For that, you must understand that AF works physiologically in different ways. One is the heart rate goes up, so diastole shortens. That's not good in a heart failure patient. The rhythm becomes irregular. The diastolic filling varies bit to bit. That is not good in a heart failure patient. Secondly, there is a loss of AV synchrony. The atria beat at 250 to 300, the ventricles beat at 120, 130. This AV dyssynchrony is not good for a heart failure patient. And then there are certain other underlying pathologies of which maybe ischemia you can treat, but left ventricular hypertrophy is something that you cannot address acutely. And left ventricular ejection fraction is again a result of the large MI or something like that. So therefore, you have to target the first three things. And what do I mean by that? If you control the rate, what you are doing is you are controlling the fast heart rate, targeting the fast heart rate. If you control the rhythm, you're targeting not only the fast heart rate, but irregularity as well as restoring the AV synchrony. So it seems attractive that the sinus rhythm, that reverting to sinus rhythm is always a better option, but you have to balance it against whether the AF was old, whether the patient is adequately anticoagulated, whether there's a continued need of inotropes, and whether he is likely to maintain the sinus rhythm based on the milieu that you are finding this patient in. So whether you do a rate control or rhythm control is has to be, the tactics have to be decided based on the milieu or the background of the ACS scenario that the patient is in. So once again, some of these AF episodes will come and go, and every inotrope is essentially every an antiarrhythmic is essentially in some way a negative inotrope. So when you have self-limited episodes, it is necessary to remember that you don't push too many antiarrhythmic drugs because they are negative inotropes. So therefore, some episodes that are short, well tolerated, and terminate spontaneously, you may just watch and see what's happening. If you have to do a rate control for a couple of reasons that I discussed, then beta blockers may be your drug of choice when the patient is not on an inotrope. So if somebody is not on noradrenaline or dobutamine, then beta blocker is your drug to go in a stable patient who has a good blood pressure, who is not in frank left ventricular failure. Calcium channel blockers are an absolute no-no because they will worsen the left ventricular failure because of the negative inotropic action. You know that diltiazem and verapamil are the drugs used, but they are not the preferred drugs in this setting. If you have a patient who is in heart failure and requires inotropes, then you cannot use beta blocker in a wet patient. So you have to use amiodarone in this case as a rate control agent. So normally amiodarone is a rhythm restoring or a rhythm maintaining agent. But here you have to use the AV node blocking properties of amiodarone, and therefore initiating IV amiodarone with the idea of rate control is perfectly okay in this scenario. Digoxin, use of digoxin or rapid digitalization, somehow I feel is a forgotten art. Digoxin works in the scenarios where the creatinine is not high, you are not intending to restore sinus rhythm. Digoxin rapid digitalization, IV rapid digitalization will give you a rate control along with amiodarone and may help you to tide over or stabilize the hemodynamics of the patient. And at times, the patient is really hemodynamically unstable. You can't get him out of the failure. Luckily, it is not more than 48 hours that you have to, that the patient is in AFib, and your amiodarone after 24 hours or 48 hours is not able to restore sinus rhythm. You don't have to delay the cardioversion further. If you cardiovert, you have a more reliable chance of getting into sinus rhythm. Mind you, I didn't say maintaining sinus rhythm, but the possibility of reverting to sinus rhythm is much better with DC cardioversion than with IV amiodarone. So therefore, when you have already given IV amiodarone for 24 to 48 hours, are not able to restore sinus rhythm, then take that call to DC cardiovert to sinus rhythm, because now under the already infused IV amiodarone, the chance of maintaining sinus rhythm is going to be much better. So therefore, DC cardioversion. Again, don't be reluctant. Many of the ICUs are reluctant to do DC cardioversion for AFib, but it is a very reliable way to restore sinus rhythm. The last leg of this presentation is about AV block. Now, AV node has a dual supply from the right coronary artery as well as the septal perforator branch of the left anterior descending. And normally, the AV conduction in the setting of an acute coronary syndrome or in the setting of a STEMI tends to recover because of this dual supply. But what is more damning in this scenario in the patient who has AV block is that they could be having a large myocardial infarction, and the size of the myocardial infarction that is going to determine the prognosis. Probably the AV conduction is bound to recover. These days, it does recover much more often because of the aggressive availability of a good thrombolytic agent and the possibility to do a primary angioplasty. So we see this AV block today much less uncommonly, so less than 5%. Previously, as a trainee, I used to see that much more often, but these days we see it very uncommonly. The dual supply and the thrombolysis and the PAMI helps in a big way too. So here is a patient. So this AV blocks in acute MI can present in two scenarios. One is patient clearly presents to the emergency medical system with angina, and you did a ECG and you documented the AMI, acute inferior wall MI, you're happy, correct, but don't forget to realize that there is a bradycardia, and this bradycardia clearly comes from the AV block. And then the other scenario is a little, so here if you were to do an angioplasty, you find RCA occluded. The moment you relieve this RCA block, you have a reversal of AV block in most scenarios. The second scenario can be a little confusing. You have a patient who drives into the EMS at 1 o'clock in the night after a party, and he's talking of abdominal discomfort. You ask him whether he's had alcohol because he's gone to a party. He says yes. You concentrate on that, and you may not record a ECG, but you have to be a little more clinical. And if you record a ECG, you again see this and you see the rhythm strip, and you're happy that you're diagnosed a AV block, and that explains some of his giddiness. But you sometimes do not see that there's an inferior wall MI that is causing AV block. So sometimes the symptoms can be atypical and the bradycardia may be more attractive, but you have to see that the underlying cause is an MI and should not be missed, because this patient deserves a primary angioplasty. So therefore, there could be a difference in the presentations. But these are some of the facts. This paper comes from 2021, so not such an old publication. It clearly shows that complete heart block has become less frequent in the PCI era for the PAMI era, I must say. But it is associated patients who have AV block in a STEMI setting have a higher in hospital mortality because of the larger myocardium that has been at jeopardy in these settings. And if one comes out of this AV block and does the right things, then the long-term mortality because of the AV block in STEMI does not seem to be affected. So long-term mortality does not get affected. They usually don't require pacemaker. Short-term mortality, you need a better critical care handling to prevent an mortality. Now look at this. Is there a difference between the AV block or a complete heart block, whether it happens in an anterior wall or the inferior wall MI setting? Now, the general rule is that If you have it in inferior wall MI setting, they almost never land up requiring a pacemaker. Any minor degree of AV block, that is first degree or second degree, usually does not require a pacemaker. But if you have in an anterior MI setting a complete heart block with a wide QRS, they are the few ones who may require a pacemaker. Question is when to make that indication. But an anterior wall MI with a complete heart block that persists, very small number of patients could become an indication for a pacemaker. Now, these are the guidelines from 2018, which clearly say that if you have a AV block in an AMI setting which resolves, no permanent pacemaker. If the AV block is, let me call it minor, like a bundle branch block or a fascicular block or a second, but not a type 2 second degree AV block or a complete heart block, there is no question of permanent pacing. If you get a high-grade AV block like Mobitz type 2, a high-grade AV block with alternating bundle branch block or a third-degree AV block, so all these are high-grade AV conduction disorders. Second-degree Mobitz block, two P waves blocked, and then one P wave conducted, that is a high-grade AV block. Alternating bundle branch block, that is right bundle, left bundle, and third-degree AV block. Now, these are indications for permanent pacing normally, but there is a waiting period prescribed. Usually it's at least a week in an interval MI setting before you decide to do a pacemaker. So you have to, in MI setting, believe that the AV block is going to recover, and only if it persists, the high grade AV block persists, and you cross the waiting period, then it is time to decide a pacemaker. So I think I'm up on my time, probably exceeded a couple of minutes. But in conclusion, what did I tell you in the last couple of in this session is that ventricular arrhythmias, do not think that they are only the ones that you see in the ICU, but there are pre-admission cardiac arrests. Sudden cardiac deaths are related to acute coronary syndrome. When you get the patient in the ICU and you see a ventricular arrhythmia, differentiate whether it is polymorphic or a monomorphic VT. Polymorphic VT is usually requires aggressive management of the ischemia. Monomorphic VT can happen in people who have previous MI, and particularly those ones. So this is a second myocardial infarction. These people may get monomorphic VT. If you get such a VT between 48 to 6 weeks, 48 hours to discharge, then do consult an electrophysiologist about what your approach should be. Ejection fraction is the ultimate decider of how this patient does. Atrial fibrillation is not directly linked to mortality, but it prolongs the ICU stay. You have to tailor your call to rate or rhythm control depending on the milieu of a particular patient. You have to individualize how you go about AFib in this patient. Luckily, AV block requiring a pacemaker is much uncommon in today's world of aggressive revascularization. But if it happens, then you will have to again manage the patient good in the acute setting. Long-term mortality is usually not going to be affected, so it seems. I think I'll stop here, and if there are one or two comments from my co-faculty, Dr. Mohan or Dr. Mandar, you may just quickly make some remarks, and then I'll request Dr. Mohan to make his presentation. Thank you very much for your patience.
Yeah, that was an excellent overview of arrhythmias in ACS settings, Dr. Ashish. A couple of questions. One thing is, it's very clear that if the patient does have a polymorphic ventricular tachycardia within first 48 hours, it is called as primary ventricular arrhythmia, and we don't need any AICD or anything. On the contrary, if it is a monomorphic tachycardia, like you said, occurring after 48 hours, we know it is secondary arrhythmia. And then these patients may eventually, if there is LV dysfunction, may eventually go on to require a AICD. Now, there is a third set of patients. Sometimes, recently we had a patient who had a polymorphic ventricular tachycardia degenerating into torsades, requiring emergency cardioversion. But it was just after 48 hours of completion. So it was somewhere around 60-65 hours of onset of MI. So in these situations, do we still wait? This patient had LV dysfunction, ejection fraction of 30%, revascularized. So will this person qualify for AICD for secondary prevention, or do we still wait for 40 days and wait for ejection fraction to improve?
Right. So, these are typically tricky situations and you have to tailor them to the individual patient's milieu. For example, if you think that you have adequately revascularized the patient and in a good time frame, if you think that there are no inotropes going on that would have been responsible for instigating this ventricular arrhythmia, if you think that the QT was reasonable, there was no bradycardia and the electrolytes were fine, so in a patient who was in the wards or in the rooms and who was stable and was about to be discharged, if he lands up with such an arrhythmia, I think there is a case for a defibrillator, depending on whatever that arrhythmia is, because there is no instigating factor and it is purely out of the scar that it has happened. But on the other hand, if this patient is still in ICU on a high dose of inotropes, if there is a more critical culprit vessel that can be managed, if he is still a wet with LVF ongoing, then in such patients, I would think that I would wait for a recurrence in hospital, or I would see that I can optimize the medical therapy, then take a call. The whole understanding is that whether there is an instigating factor or not, and secondly, whether this patient has a survival for, say, at least an year, and that's when you decide to give an ICD. What the trials found out that if you were too early in implanting an ICD, then these patients have other competing causes of death in the next 1 year, and your ICD doesn't stand to benefit this patient. So that is the whole understanding. So you have to kind of see the milieu in which you have to make the decision. And sometimes I have made a decision for an ICD in the moratorium period. Most of the times you are trying to wait and look for an instigating cause and then see whether you can avoid an ICD.
Right, Dr. Ashish. Thank you. That
Dr. Mohan,
comprehensively answers the question. Thank you.
yeah, thanks. Dr. Mohan, any
Dr.
comments?
Dr. Ashish, one of the problems which we clinicians regularly face is there is a patient who has undergone primary PCI, largely for anti-valvular infarction, and he is seen on first visit, let's say 7 or 10 days after discharge, and has an ejection fraction below 35%. We understand you need to wait for 6 weeks before you decide whether primary prevention by ICD should be performed or not. However, there is so much variability with regard to the advice which cardiologists versus electrophysiologists provide to this patient that the patient gets pretty much confused. What would be your strategy? Would you suggest in these individuals to do a loop recording before deciding to give an early ICD? Wait regularly in absence of symptoms, or preempt, or let's say jump the gun in case there are complex arrhythmias during intervening period?
So I think this is a very interesting question, and the discussion is important from the perspective of the attendees. That that there is a clear white and black about AMI, about ventricular arrhythmia in the first 48 hours, when you can officially label it as a primary ventricular arrhythmia and decide to stay away from an ICD. There is a clear understanding in the scientific community or the medical community about a ventricular arrhythmia which happens after, say, 6 weeks. When you know it, you can clearly call it secondary. Yes, anything after 48 hours is also secondary by definition. The question is, do we understand, do we realize that this arrhythmia is going to recur? And I said a couple of things. Dr. Mohan's question is still much more instigating in the sense that he says that it is purely on ejection fraction that is below 35% in this time of discharge to 6 weeks, when you have the moratorium, whether you are going to talk of an ICD. Now, I think I'm going to be very upfront with this patient, and I think most of us should be saying that this is a gray zone. It might be too early to do an ICD in this setting just on the basis of ejection fraction, because ICDs have their own consequences in terms of inappropriate therapies, in terms of selecting the right device, in terms of the battery life of the device, so inappropriate therapy. So there are a couple of things that are tried to ICD, and even if you have the, if you are, even if you are a money bags, it doesn't mean that you have made the right decision by giving the ICD so early. So therefore, this decision ought to be pretty forthright. If on the other hand, in this time, if that patient comes with some palpitations or some pre-syncope or a giddiness kind of syncope or a frank syncope, then the strategy would obviously turn on its head. And the more you are convinced about that symptom being arrhythmic in nature, the more you would have a knee-jerk reaction to give ICD, and which I find is fair. If you are not convinced, as was proposed, you might do a long-term rhythm monitoring. And thankfully today we have a lot of such easy devices like the external loop recorders to see whether somebody is getting a ventricular arrhythmia. And the moment you see a non-sustained VT and a pre-syncope symptom in this period, even if it's moratorium, I think you will be quite qualified to say that ICD, I'll make an exception and discuss an ICD with this patient. So it ought to be a pretty tailored approach. I think a general thing based purely on ejection fraction as a primary prevention indication in this moratorium period would be unjustified. That's the understanding that we go on with currently. Thank you for the question, Dr. Mohan. Sure. So I think we also need to keep to time considering the Sunday. I'm sure Dr. Mohan Professor Mohan is ready with his slides, and I'll request him to enlighten us on what is true about the contemporary use of beta blockers in the present days. Dr. Mohan, the floor is yours.
Thank you. Can you allow me to share? Can you stop these slides, please?
Yes.
All right. So
yes, your slides are screen. Maybe
to be honest, I had no idea I'm speaking. Maybe it was my mistake, or maybe this was a miscommunication. And so these are my random thoughts on beta blockers in coronary artery disease, sudden cardiac death, and miscellaneous. And you might not find really that strong tenuous continuity, but I think I will bring out the message. Raymond Alquist in 1948 classified the adrenergic receptors into alpha 1, alpha 2, beta 1, and beta 2. Beta 3 receptors, which are largely found in brown fat and prostate, were discovered much later on. James Black, who received Nobel Prize in 1960, was the first person to use beta blockers in management of hypertension, and he used propranolol. These 65 years, we have come a long way with regard to use and re-evaluation of beta blockers in multiple conditions, including coronary artery disease, heart failure, sudden cardiac death. So where are beta adrenergic receptors? These are, of course, transmembrane receptors. And beta 1 are largely present actually in the heart, and beta 2 are in vasculature and gut and bronchial musculature. And when beta adrenergic receptors are stimulated by epinephrine or norepinephrine, these in turn actually stimulate adenyl cyclase enzyme, which is again a transmembrane enzyme, and that results in increased cyclic AMP within the cell. This cyclic AMP phosphorylates protein kinase A, and which further phosphorylates ryanodine receptors, voltage operating calcium channels, and also the end result actually is a series of activities which would increase contractility, which would increase heart rate, and there are other things like thermogenesis and effect on the conduction system or effect on conduction properties of the conduction system. So the nerve endings bring epinephrine and norepinephrine. These work on beta receptors and usually on myocardium, but also on other tissues. So far what I have said is that catecholamines increase cyclic AMP, which is a second order messenger in the cells, which increases the phosphokinase A, which phosphorylates multiple molecules in the cell, including ryanodine receptors. Beta-adrenergic receptors also get phosphorylated, and there are voltage operating channels which get phosphorylated. However, excess of catecholamines leads to hyperphosphorylation, leading to excess cytosolic calcium, endocytosis of beta receptors. If they get hyperphosphorylated, these decrease in number, intensity, density, and activity. And there is also inactivation of ryanodine 2 receptors, which are involved in calcium transient within the myocardial cells. So constant overactivation in early stages of multiple conditions, including coronary artery disease, stable coronary artery disease, post-MI and heart failure, would lead to reduction in the beta-adrenergic receptor reserve, response, and intensity. Beta blockers are of several types available. Those which most commonly we use are neutral antagonists, but we also have which have beta blockers with partial agonism and inverse agonism. We wouldn't go in these details because essentially we are going to talk about role of beta blockers in miscellaneous conditions. Now, but with regard to these three different properties, problem with life is there are infinite choices with regard to beta blockers. And one of the things which we need to actually discuss is how to choose a beta blocker. Well, we wouldn't go again in greater details, but the beta blockers vary depending upon the gut absorption, bioavailability, metabolism, hydrophilicity versus lipophilicity, the ability to cross blood-brain barrier, intrinsic sympathetic activity, and selectivity for beta-1 receptors. We know that bisoprolol and nebivolol have the highest beta-1 selectivity compared to metoprolol, and drugs like propranolol are relatively non-selective. A word about bisoprolol, since this has become the most commonly used beta blocker now in the country in the hands of cardiologists, not necessarily in the hands of physicians, because it is highly cardioselective, it has a prolonged half-life of 17 hours, high bioavailability, renal excretion is less, it is hydrophilic, doesn't cross blood-brain barrier, so you don't get nightmares and other things, and it is 30% protein bound, so it has a higher bioavailability. And you can give it actually up to a very low EGFR. When the EGFR falls less than 10 ml, only then you have to reduce the dose, because now the minimum inhibitory concentration goes up by 2 times. Few things where there is obvious sympathetic overactivation is post-MI patients and heart failure with reduced ejection fraction. These are individuals who at tissue level show hypoperfusion because of low blood pressure, low cardiac output, and low renal blood flow. And this sympathetic overactivity in the initial stages is meant to be compensatory to improve cardiac output and contractility. However, prolonged sympathetic overactivity leads to desensitized beta receptors, apoptosis, necrosis, hypertrophy, autophagy, and fibrosis. All those things which are undesirable and need to be counteracted. That is why beta blockers have an invaluable role in HFrEF and post-MI patients and other patients with left ventricle systolic dysfunction, which may be ischemic, may not be ischemic. Major mechanisms of actions of beta blockers are that they neutralize cardiotoxic catecholamines, anti-ischemic action. We will talk about it. So its role in stable coronary artery disease and silent ischemia. These work as antihypertensive drugs, block renin release from the kidneys, antiarrhythmic action, and we'll talk about it a little bit. Improved myocardial energetics, there is inhibition of apoptosis, it reduces the shear stress on plaques and hence prevents myocardial infarction. Beta blockers also work as antioxidant. These are shown to be anti-inflammatory. These upregulate beta receptors and hence increase the endogenous beta receptor activity, and maybe in the long run these might improve contractility. And of course, some beta blockers have antiplatelet activity. And there is increased myocardial gene expression essentially of the ion channels. And those ion channels which are down-regulated because of decreased mRNA are regularly upregulated, and this may be one of the important anti-arrhythmic mechanism in patients with coronary artery disease. We come to the role of beta blockers in common condition, and that is stable angina. Stable angina occurs because the oxygen demand is increased and supply is relatively fixed, and that happens because of four factors: heart rate, systolic blood pressure, contractility, and afterload. Beta blockers decrease heart rate, decrease systolic blood pressure, decrease contractile force, and hence will decrease oxygen demand. And it is logical that these would be used in patients with stable coronary artery disease with angina and patients who have silent ischemia. That is why most guidelines, including the American guidelines, suggest that beta blockers are first-line therapy for chronic stable angina. And only when these fail, you can add calcium channel blockers, long-acting nitrates, and then, of course, you can go on finally to revascularization. So far as role of beta blockers in chronic stable angina is concerned, it's a class 1A indication, pretty much established. However, what is the critique about it? The critique is when you look at stable coronary artery disease and you compare beta blockers with calcium channel blockers, and this is a meta-analysis of multiple studies, say that when you talk about death and myocardial infarction, those are not affected by beta blockers any more than calcium channel blockers. And discontinuation rates of beta blockers, of course, are lower compared to calcium channel blockers. So the advantage of beta blockers is a much lower discontinuation compared to calcium channel blockers because of headache and vasodilatation, which occurs because of CCB. But with regard to hard endpoints, there is nothing to choose between the two. We also have to remember that anti-angina drugs don't reduce mortality. Clarify registry, in which we also participated, actually showed that cardiovascular mortality with beta blockers is, or all-cause mortality with beta blockers is no better than placebo, indicating that the drug reduces symptoms, it reduces ischemia, but has no effect on hard endpoints of myocardial infarction in stable coronary artery disease, all-cause mortality, and cardiovascular mortality. So currently, we do use actually the beta blocker as first-line therapy, but of course, their major role would come in patients who have actually LV dysfunction. In normal LV function, actually, you can, in a high-risk individual, consider revascularization therapy. In low-risk individuals, based on stress test, you can give any of the medical therapies, what we call a diamond approach. You can use beta blockers, long-acting nitrates, calcium channel blocker, ranolazine, trimetazidine, anything, and none has been shown to be inferior to beta blockers. We come to the other aspect of coronary artery disease, that is post-myocardial infarction and role of beta blockers. We have a good number of trials. Some of these are listed here, including beta blocker heart attack trial, which was the seminal trial which put propranolol use in post-MI patients. So then we have Norwegian Timolol trial, Miami trial, which was a relatively negative trial. Subgroup was positive with metoprolol. Chinese Comet trial with metoprolol, early metoprolol intravenous use was found to be harmful in acute myocardial infarction, where GC trial, which was positive, reduced AMI, which is the most recent trial. And that is very, very interesting, actually, which Sanjit Jolly presented in AHA just a few months back. And we have data from Capricorn study, which was MI with LV dysfunction. I did mention why there is so variable response in myocardial infarction and beta blockers is because if you have molecular web which is altered, then beta blockers would work. The molecular web gets altered in post-MI patients with LV dysfunction. HFrEF patients and LV systolic dysfunction. So what happens is that because of hyperphosphorylated ryanodine receptor, because of chronic overactivation of beta blockers, there is increased cytosolic calcium and decreased mitochondrial calcium. And through working through many channels and ions, essentially it leads to apoptosis, autophagy, and of course, increase oxygen utilization without improving the contractility. And the end result obviously is that if LV function is down, oxygen consumption is more, and there are harmful molecular activity going on like apoptosis, necrosis, and autophagy. Normally, of course, calcium, intracellular calcium is less than 25 nanomoles and gets more than 100 nanomole in certain circumstances, only where the beta blockers will work. So in a patient of acute myocardial infarction who has ejection fraction which is 50% or more, that doesn't happen, and you don't expect beta blockers to work in that. So beta blockers, now there is a nuanced understanding about beta blockers. When do beta blockers work in acute MI and when they do not work? Essentially, if there is an intracellular calcium transport which is altered, then only beta blockers work, because essentially they restore the stoichiometry of ryanodine receptors and also the pKa activity. We also discussed that the chronic beta blockers decrease sympathetic tone, and those will result in apoptosis, QT dispersion. The decreased sympathetic tone will decrease the QT dispersion, and that is an important anti-arrhythmic mechanism. And of course, there are other mechanisms which produce actually anti-arrhythmic effect. We have data that the heart rate increase is associated with increased mortality in myocardial infarction, but this GC3 data is of the time actually when the thrombolysis or revascularization was quite uncommon. And in patients who have not undergone revascularization, heart rate is a strong parameter of mortality, and beta blockers consequently have a tremendous benefit. However, both heart rate and beta blockers are losing relevance when patients have been revascularized following acute myocardial infarction. And we would talk about that. However, in an era when revascularization was not that common, and this is Capricorn study, in post-MI patient with ejection fraction less than 40%, I'm pretty sure this is still relevant, but to a lesser extent. There is a decrease in AF and atrial flutter by 57%, decrease in VT/VF by 76%. One of the important reasons why sudden cardiac death is reduced in patients with post-MI LV dysfunction, and we still continue to use, although that kind of benefit now in an era of complete revascularization would be difficult to show that kind of tremendous benefit of 76% reduction in VT/VF. There are new things actually which are happening with regard to beta blockers, and that is that there is a remodeling of ion channels which plays an important role as mechanism of arrhythmias, and beta blockers upregulate certain potassium channel subunits and also sodium channel subunits, and this way these serve as prevent potential fatal arrhythmias. We also know that beta blockers reduce the ventricular repolarization heterogeneity, and also these prevent the remodeling of ion channels to definite mechanisms of anti-arrhythmic efficacy. Besides, and this later part actually has been actually called as membrane stabilizing effect of beta blockers. Beta blockers have been used in heart failure, largely patients both ischemic and non-ischemic. The CBS-1 trial was the pivotal trial which actually showed that there is a trend towards decrease all-cause deaths. And of course, when you looked at the both all-cause death and hospital for heart failure, there was significant benefit. What what we got interested was in CBIS-2 trial, largely patients with coronary artery disease, 65% of these patients with previous myocardial infarction with ejection fraction less than 35%. Sudden cardiac death was reduced by 44%. Overall benefit with regard to primary endpoint of all-cause death plus hospital for heart failure was reduced by 34%, but sudden cardiac death was significantly reduced by 44% with number needed treatment 37 in a 1 year's time, indicating that beta blockers have great antiarrhythmic role essentially in patients with heart failure with reduced ejection fraction. However, come to 2024, and we have this reduced MI study presented in Nature by Sanjeet Jolly. These are patients with acute myocardial infarction who have undergone revascularization, and now they have an ejection fraction of more than 50%. You find that whether you give beta blockers or you do not give beta blockers, the cumulative incidence of sudden cardiac death, all-cause death, hospitalized for heart failure, resuscitation from VTVF, and hospitalized for heart failure are no different whether you gave to these individuals beta blockers or not. It's a large study of more than 5,000 patients, and it is trying to tell us that now the role of beta blockers needs to be reassessed in post-acute myocardial infarction patients. More data, and this, of course, new myocardial infarction is also not reduced by use of beta blocker. Now you would remember the beta blocker heart attack trial, where new myocardial infarction was reduced by 25%, 26% to be precise, with beta blocker heart attack trial. In Capricorn, which was post LV dysfunction patient with a post MI, re-MI was reduced by 40%. But now you see when you have ejection fraction more than 50%, since now there is no overactivation of sympathetic overactivity, there is molecular web is not deranged in myocytes, beta blockers don't seem to be providing any benefit. So conclusion of reduced AMI study has been that long-term beta blocker treatment does not lead to lower risk of composite primary endpoints or death from any cause or new myocardial infarction than with no beta blocker. So I would actually sum up my presentation by saying that beta blockers have still utility in stable coronary artery disease with angina and possibly silent ischemia, post-MI with LV dysfunction, and also in heart failure with reduced ejection fraction. But beta blockers are being critically reassessed and reanalyzed now in light of the new evidence. Thank you very much.
Sure. Thanks, Professor Mohan. That's very succinct. We are sorry that some of this communication was missed, but we didn't feel at any point in time that we missed anything to learn from this topic, certainly when you are the speaker. A couple of questions maybe before I give Mandar the possibility to ask. How early do you initiate beta blockers in an ACS setting? And when do you delay the initiation of beta blockers in the ACS setting?
So first question first, how early you start? The COMET trial actually showed that within 24 hours it is not safe to start beta blockers. The chances of myocardial rupture are a little bit high. So I probably would say that after 24 hours, when patient is hemodynamically stable, you could start beta blockers. It is also possible that you can still delay it by 1 or 2 more days. We also have data actually from Capricorn study, which has shown that the first 7 days, you don't see much benefit of beta blockers with regard to any of the events. I would be happy actually, and we also have actually data from ISIS-2 study, where atenolol was shown to be beneficial post-MI but they also started between 3 and 7 days actually. So my guess would be that maybe first 24 to 48 hours, I would not, and then we will start. The second part of the question was, I, I, I,
When
I
would you,
forgot.
when do you delay, when would you delay the use
Yeah,
of beta
when would you
blockers?
delay? So I am pretty sure that patients who are decompensated, I would delay it. That means they have fluid overload. I would also, when patients have mechanical complications, I would delay. I would like the patient to get a little more stabilized. When patients have relatively low blood pressure, or patient also has atrioventricular blocks, bifascicular, trifascicular block, I probably would wait for a while.
Do you have a choice of beta blocker depending on the patient subset? Can you clarify a bit on that for our attendees?
Yeah, so the experience has taught us one thing, that the carvedilol lowers blood pressure more than metoprolol, and metoprolol lowers more than bisoprolol. If the hemodynamics are borderline, blood pressure borderline, bisoprolol is a better choice. Sexual dysfunction actually is least with bisoprolol, and hence this is another reason we tend to choose this more often. We also have looked at the metabolic derangements with 3 molecules, and there are actually some head-to-head comparisons of low quality, which have shown that the metabolic derangement is least with the bisoprolol. Fourth point is that bisoprolol up to the 10 ml EGFR can be used in the regular doses, and later on, of course, you can reduce the dose. These are 4 or 5 reasons I tend to use bisoprolol far more, and once a day. And probably my dose response has linearity. Dose response, the response and the dose of the drug have linearity, and I probably that is why I like bisoprolol much more. It doesn't have first pass effect. It doesn't. It is hydrophilic drug, so it doesn't cross the blood-brain barrier. Multiple reasons why. Of course, carvedilol also does not cross blood-brain barrier, but carvedilol largely has to be given twice a day. The single dose which is available in India doesn't have too much of evidence, and then the fact remains that the borderline hemodynamics, I wouldn't prefer carvedilol. Carvedilol probably has a more value in patients with portal hypertension with heart failure, but that is a very small subset.
So, heart rate reduction is a very important aspect in this ACS setting because it has benefits of treating the heart failure better, ischemia better. So, what is the difference for the clarity of our attendees? What is the difference between using ivabradine and beta blocker, and how do you combine it beneficially? Can you dwell a bit on that?
Yeah, so that's a pretty good. First thing, of course, the two mechanism of actions are different. The ivabradine works on HCN so it is a sinus node, direct sinus node inhibitor, while beta blockers work through the adrenergic receptors. Ivabradine would not reduce the blood pressure. The other thing is it does not curtail the diastolic filling period. So ivabradine actually has these two advantages. Disadvantages are it doesn't reduce mortality. There's no data actually. I mean, there is subgroup analysis of shift trials indicating that cardiovascular mortality was reduced, but still there was no reduction of all-cause mortality with ivabradine. The Carviva study has shown that the ivabradine improves exercise capacity. Beta blockers don't improve exercise capacity. VO2 max remains unchanged with beta blockers. 6-minute walk time remains unchanged beta blocker, and giving ivabradine actually alone or with beta blockers when combined probably will improve the exercise capacity. Question actually is whenever hemodynamics are unstable, whenever you have lower blood pressure, you can either start ivabradine alone or a very small dose of beta blockers with ivabradine, and as things stabilize, take away the ivabradine. We do it quite often in almost 25% of our patients, even in post-MI setting, even in patients post-MI with low cardiac output state and HFrEF patient. Any specific issue on that? The point actually remains that the bulk of the data is with beta blockers, much more. Ivabradine, there is a single trial which we keep harping Beautiful was essentially a negative trial. Subgroup analysis was positive in those who have ejection fraction less than 35%. But we need to remember that ivabradine as an adjuvant to beta blocker or without that has some role post MI LV dysfunction as well as HFrEF and multiple other conditions where you want to reduce the heart rate.
Wonderfully put. Mandar, you want to clarify a few things with Dr. Mohan?
Yeah. So Dr. Mohan, that was an amazing talk. Back to the basics type of a talk. Thoroughly enjoyed. Thank you so much. So one of the questions is, see, one of the contraindications for beta blockers obviously is bronchial asthma, but there is still lack of clarity amongst clinicians whether the same applies in patients with COPD. So some clinicians are hesitant to give beta blockers in COPD, saying that condition might worsen. Some other physicians say that no, COPD is completely different from bronchial asthma, and beta blockers are okay to be given in COPD. So is there any take on this?
So actually, there is large amount of registry data and post hoc analysis in COPD patient with beta blockers, and all have shown that these drugs are safe. That you do get slight decrease in FVC, but it's not of clinical significance, largely because the drugs more beta 1 selective do not work on bronchial musculature. Having said that, I think a cautious approach is you look at the response of the patient as you are increasing the dose. Don't start with the maximal dose straight away. I think between what is published and what we do, there should be some common sense, because the sensical thing is small with small dose and keep looking at things. There isn't any harm actually, even in looking at pulmonary function tests. An occasional patient may have very unusual response. Largely, beta blockers are tolerated. More selective like nebivolol and bisoprolol are tolerated better.
Thank you, sir.
Sure. I think that was an excellent session on beta blockers. And I'm sure the audience will be more encouraged and enhance their use of beta blockers. It's really a Kamdhenu of cardiology. So I think we will not shy away too much from it, but carefully escalate it to the maximum doses depending on your patient's response and parameters. So sure. So I think let's move on to a more hands-on session, which is the last leg of this CME, and that is about CPR. And I think I have made enough introduction in my talk, and I wouldn't do too much now. Just having introduced Dr. Mandar Shah as a very judicious interventional cardiologist. This is another aspect that is close to his heart, CPR training, and I'm sure he has a lot from the real world to tell us about how he trains and how this should be done, and what is hands-on, and what is the role of defibrillator and all that. So I think Mandar, let's get on with your presentation.
Am I audible? And is my screen visible?
Yeah, you are audible, and I think your first slide
Blue
is probably
only
a blank
blank
slide,
blue.
but
Yeah.
yeah, sure. So you're starting. Okay.
Perfect. So, Dr. Ashish, the topic that was given to me was not exactly how to perform CPR, because that I think has already been covered in previous 3 sessions. So what I was made to understand is, this is the talk that I was given. Role of CSR initiatives for AED installations. So probably the talk was given because I work in an industrial hospital. I work in Tata Main Hospital, which is run by Tata Steel. And so the organizers wanted to know whether corporates, industry can help in increasing AED installations. So to be honest, when I first received this topic, I was a bit overwhelmed. What am I going to talk for 25-30 minutes on CSR initiatives? But thanks to my association with Tata's, I do have an interaction with the top management, and then I do have access to people who look after CSR, and I had a lot of interaction with all of them, and I've tried to bring their insights into the talk, so I hope it is useful. So my talk will be restricted to CSR initiatives for AED installations. So all of us are aware of story of our beloved Dr. APJ Abdul Kalam. He was delivering a talk at IIM Shillong. He was his lively self, humorous, charismatic as ever. And while delivering talk on the podium itself, he had a collapse, a sudden collapse because of sudden cardiac arrest. Now, unfortunately, there was not a single person from the August audience. Mind you, the talk was at IIM Shillong. So all highly educated public sitting out over there, not a single person came forward to give him CPR. So the next picture is very telling. It's as if Dr. Kalam is pleading to the audience, please come give me CPR. I have enough of life left in me. If you bring me out of this episode, if you cannot do it, I wish I could have come out and given CPR onto myself. But even after having given CPR, would that have been sufficient? All of us know, Dr. Ashish also stressed in his talk, that majority of sudden cardiac arrests occur because of this rhythm, either a polymorphic VT or a VF or a torsades, which only by CPR is just going to buy you time. Ultimate therapy for this is delivering a shock. So you've got a ventricular fibrillation ongoing, you deliver a shock, the rhythm is restored back to sinus rhythm, and this is how a patient's life is saved. So only if he had received timely CPR along with defibrillator, Dr. Kalam would have perhaps still been present with us, motivating us, inspiring us. Unfortunately, not to be. So let me take this opportunity to focus on burden of sudden cardiac deaths and sudden cardiac arrests. So incidence is not less, 1 to 2 per 1,000 people annually. So the incidence of PSVT, supraventricular tachycardias, is almost the same, 1 to 2 per 1,000 people annually. So similar rate. So it's not an uncommon entity at all. So it results in millions of lives lost globally due to sudden cardiac deaths. Now, there is a bimodal distribution. It is not that children are protected from sudden cardiac arrest. All of us know that we have seen children, young adults, all of them falling victims to sudden cardiac arrest and sudden cardiac death. In the only differences in children and young adults, it is usually because of some channelopathies, some genetic abnormalities, whereas in elderly people, it is predominantly because of structural heart disease, heart failures, MIs, etc. What is sad is 70 to 80% of these cases occur outside the hospital setting, with resultant survival as low as 5 to 10%, even in developed countries, where bystander CPR rate is much higher. As compared to that, in India, there was a recent article published in Indian Heart Journal that says that CPR bystander rate is just 1.3 to 9.8%. That means if some patient has had to have a sudden cardiac arrest in outside the hospital setting, then only 1% to 9% probability that somebody will come forward to give him CPR. Forget about the end result of CPR. CPR is initiated itself in 1 to 9% of cases, as against AHA target of 62%. And once again, the importance of sudden cardiac arrest. The thing is, if we institute therapy resuscitation early within first 1 minute, chances of survival are more than 90%. On the contrary, as time passes, the chances of survival keep on reducing. So time is indeed life in this case. And when CPR is combined with AED is automated external defibrillator, chances of survival increase by as much as 30 to 50% when used along with CPR. And it is very easy to use even for a non-medico. It is an automated thing. One doesn't need to do anything, just need to attach the pads and defib will give its own instructions what needs to be done. So where should AEDs be installed? schools and colleges, malls, multiplexes, auditoriums, theaters, parks, markets, stadiums, airports, bus stands, railway stations, cafeteria, restaurants, offices, factories, housing societies, and residential colonies. So anywhere where there is an increased footfall of people, AED should be installed, because you never know which is the place where a person is going to develop sudden cardiac arrest and collapse. Now let me tell you data about AED installations in Jamshedpur. Now, Jamshedpur is one of the biggest towns in Jharkhand state. It has got 73 private schools, several colleges, several other public schools, and yet not a single school or a college has AED installed within it. Malls, multiplexes, auditoriums. Jamshedpur has got huge parks, big parks, world famous ones, but not a single defibrillator in any of these parks or auditoriums or multiplexes. There is one single defibrillator available in one of the malls. That's about it. We've got big stadiums. There are so many cafeteria, restaurants. None of them have a defibrillator. In fact, Jamshedpur has got a very good stadium which hosts ISL matches. So Indian Soccer League matches. So JFC, Jamshedpur Football Club, is one of the teams. And I happened to talk to CEO of JFC, who is my immediate neighbor. So I asked him that I'm sure for a tournament like ISL, defibrillators would be mandatory. He said, yes, they are mandatory. So I said, do we have one? So he said, yes, we have one. So I said, where is it? So he says, it is kept in lock and key in my office. It's not there in the stadium. What is the use of having a defibrillator in a lock and key in his cabin? So for all practical purposes, there is negligible public AED installation in Jamshedpur. Now the million-dollar question is, when the data is so crystal clear, why are we still lacking in AEDs at public places? The answer, I think, is quite clear. Who's going to do it? Is it government and politicians? Well, politicians are busy fighting amongst themselves. Government is busy changing names of cities, and opposition is busy in much more important things like saving the constitution and rather saving themselves. Who is bothered about trivial things like saving lives? So let us keep politicians aside. What about wealthy people? First of all, India doesn't have that philanthropic mindset. And even if some people have to come forward saying that we will be able to donate AEDs, the impact is going to be very small. How many AEDs can a wealthy person donate? So the impact is not going to be huge. We require thousands of AEDs across. What about NGOs? NGOs can potentially contribute, but all NGOs have got their own agendas, right? For example, there is an NGO called Save the Children. So all its funds would be diverted towards their agenda of saving children. They would not divert their funds to AED installations unless if there is a specific NGO that comes up with this specific focus of AED installations. Then what about corporates? What about Tatas, Birlas, Adanis, Ambanis? All of them have got huge footprint across the country, not just country, globe. Tatas, for example, are present everywhere, right from salt to mobiles, to steel, to automobiles, to aviation. Think of a sector and Tatas are there. So they've got a huge footprint. And there is a terminology called as CSR, Corporate Social Responsibility. So corporates are expected to give back to the society for something that is non-profitable, which they are doing for the benefit of the society. So all corporates have to do this CSR. And there is a CSR pyramid. So corporates have to have, So corporates have to have they have economic responsibility. So their most important responsibility is to be profitable, so that the business runs, the shareholders are in profit. Next in the pyramid is legal responsibilities. They have to obey the rules. Then is to be ethical. And top of the pyramid is philanthropic responsibilities. So it is through these philanthropic responsibilities that all various CSR activities take place. And India is one of the few countries, I think India, Indonesia, and South Africa. These are only few handful of countries where CSR is mandatory. Everywhere across the globe, it is an optional thing. It is a voluntary thing, which companies do, but they do it voluntarily. In India, in 2013, Company Bill Act made it mandatory for big companies to contribute towards CSR. So what does the bill state? That any company that has a net worth of more than 500 crores, or a turnover of more than 1,000 crores, or a net profit, annual profit of more than 5 crores, has to contribute at least 2% of its net average profit towards philanthropic activities for corporate social responsibility. So companies have to follow certain procedures. So they have to create a CSR committee. Tata Steel, for example, has a dedicated full-fledged department for CSR. So it's called as Tata Steel Foundation. Entire department dedicated to it. Then they have to develop policies. They have to allocate funds, implement the policies, and they are mandated to provide their reports to Ministry of Corporate Affairs of the central government. So they are anyway supposed to do CSR activities. And what accounts typically as CSR? They can work towards. So these are government given guidelines. They can work towards eradicating hunger. They can work towards environmental sustainability, or promotion of education, or gender equality, or reducing child mortality and improving maternal health, or combating HIV, other diseases, or contributing towards national disaster, Prime Minister's Relief Fund, etc. Now, nowhere over here CPR or AIDS is brought into picture, because the government is not aware of it, the corporates are not aware of it, majority of people do not have the awareness about its significance. But yet, AIDS should be a CSR priority. Why? Because AIDS do save lives with measurable impact. They are relatively low investment for big companies. They do improve public will and public goodwill, and improve brand imaging. They improve the cohesiveness within the society. They increase interaction between the company and the society. So yes, AIDS should be a CSR priority. So I took this project up with my CSR team. I said, boss, I want to install AIDS across Jamshedpur, across various locations. So what should we do? Why can't you do it? So then, and corporates can do so many other things. Like, for example, it can not just fund, it can take an initiative in increasing awareness and education. It can promote accessibility, infrastructure. It can advocate policy changes. It can sit with the government. They have got enough clout, all these top leaders of corporates, that they can sit with the government and they can influence public health policies of the government. So many things which corporates can do apart from funding. So when I took this matter up with my CSR team, I was made to understand certain things. So how do companies choose CSR projects? One thing is, it's typically for rural, marginated, and poor class of people. They said, you're telling me to install AED in a mall and a multiplex, which are marginated, poor class of people coming to malls and multiplexes. If malls have to install, why can't malls themselves or multiplexes themselves take it as an initiative towards safety? All of them have safety as a mandate. So why can't they take it up as their safety protocol and install? Why should Tata still do it for a private mall or a multiplex? Then typically projects need to be aligned with government priorities. So there will be certain public health initiatives of government. So our projects typically align with those. So there is no public health policy on AEDs. Typically, companies look for projects that are glamorous, that they can give them, a better standing in the society. Photo op opportunities are there, and they can project to the government, to the society, that we are doing so many things for all of you. He said, if I install AEDs, even 500 AEDs across Jamshedpur, how many times is it going to be used? So if it is not going to be put to use too many times, how am I going to show that we are saving so many lives? So they're not relatively less glamorous. And companies typically look for projects that benefit businesses. Now, although CSR is supposed to be philanthropic, they do philanthropy, but they will still look at how it can benefit business. Like, for example, to give you an example, Tata Steel will typically work for communities in and around 5 kilometers vicinity of its Tata Steel plant. It will do all good activities, philanthropic activities, everything. But why within the vicinity? Tomorrow, for any reason, it decides to expand its plant, and it needs to encroach onto peripheries. It needs the residents to be in its good books, so that there is minimal resistance, and society does understand that the company is doing so much for us, and this is for our own benefit. So projects typically benefiting the businesses is what the company looks for. And there are certain corporate considerations while choosing CSR. It cannot do for private entities, obviously. Typically, they look for projects that have no recurring expenses. So it is only things done for community, not for employees, constitutes CSR. Like, for example, within Tata Steel plant, the factory itself, it's a huge plant. So there are 7 AEDs installed across locations within Jamshedpur plant itself. But that does not fall under CSR category. So any activity that is taken as CSR, it should not benefit the employees, but it should benefit community at a large. And it should have measurable impact. So what do we mean by measurable impact? I'll show you through this example. There is one MANSI project, Maternal and Neonatal Survival Initiative, which Tata Steel undertakes. So they cover 4 districts: West Singhbum, East Singhbum, Saraikela, and Gumla. So 4 districts, and each and every household of each and every village is covered up under this initiative. The volunteers reach out to every household in this. They look for who is pregnant, and they look for neonatal age group children, and even children up to 5 years of age group. Look for who amongst them requires medical help, who of them are malnourished, for example. So total lives reached are 5 million. Lives impacted. Then they measure how many out of 5 million lives, people that they have approached, how many of them really required help, and how many they have been able to approach to. Out of those, how many lives were altered, and eventually how many lives were saved. So they are able to show that out of 5 million population that we approached, there were thousands of kids that were malnourished, and we have taken initiatives to improve their malnourishment and have a positive impact. So this is something that is very lucrative, which is very glamorous, which they can showcase to the government that yes, we are doing these things for the community. And are there any real world examples of AED installations as part of CSR? Well, there are certain examples that I came across. Singapore Post, for example, installed AEDs across all its post offices and mail centers. American Airlines installed AEDs across all its aircraft and airport facilities. But they were more like employers or rather employee beneficial things. Tesco installed all AEDs across 900 stores across the UK. We do not know whether these would fall under CSR because they've done for their own employees. Community will benefit eventually, but aim was not for community benefit, it was for employees. Unfortunately, there are no large-scale AED installations by companies as part of their CSR activities. That is at least not well documented. And there are certain challenges. Cost, I've mentioned as a cost because the cost will get multiplied, but that is not because one unit might not be that expensive, but when you're talking about hundreds and thousands of AEDs to be installed, the cost may multiply. But that is not so much of a factor for corporates. But limited public awareness is one of the problems. So the officer whom I had approached, he asked me how many, even if I install, say, a AED in a public place, how many people would know what it is? How many people have even heard of AEDs? Forget about using it when actually it is required. So he said, you go and check in your hospital. You work in the healthcare sector, you check in your hospital. So I went to the cath lab. I asked my nurses, how many of you have heard about AEDs? And these nurses have been using defibrillators, our hospital defibrillators, day in and day out, working in cath lab and critical care areas of ICU. So they said that no, they are not, they have never seen AED. They've only heard about it. They have never seen. So I asked them whether you are asked to use it in a public place. Will you be able to use it? They say, sir, I can use our defibrillators. But about those defibrillators, we have not seen them anytime. I do not know whether I'll be able to use or not. This is medical practitioners. What is to say about lay people? Infrastructure and accessibility. The question is simple things like whether will you lock the AED or will you keep it open? If you're going to lock it, the entire purpose is lost. But if you're not going to keep it locked, in a public place, I've installed AED in the marketplace and it is not locked. Anybody can steal it, anybody can play with it. So that's $1 million question, whether you're going to lock it or not lock it. So things like who's going to maintain it? I will install it. After installation, it needs to undergo periodic checkups. It needs to undergo battery changes. So who's going to do it? And who's going to measure how many lives are saved? And who's going to report it? All these things, are real challenges. So then I said, okay, all these are challenges, I know, but there has to be a way out. So I went and met the chief and the vice president. I said, boss, I do understand there are lots of challenges in this project, but then we still need to make Jamshedpur an AED equipped city. So what we can do? So the chief, he told me a very nice thing. He said, you need to learn to talk the language of the top management, the language the top management understands, and package it as a mission. Don't come to us saying that you install AEDs across locations. That is not going to happen. It should not come as an asset allocation. It should come packaged as a mission. So what do we mean by mission? So I tried to create a mission. So mission has to have some name. So let us say we say Dil Dharakne Do, together for a heart safe Jamshedpur. So mission has to have a logo. So you create a logo. Mission has to have some statement, some mission statement. So I make a statement to make Jamshedpur first city in the world where no lives will be lost for want of timely CPR and AED deployments. So if you make something like this, management will find it very attractive. You are making Jamshedpur the first city in the world where no lives will be lost for want of timely CPR or AED deployment. So it's more likely that management will take up such projects. And then just this much is not sufficient. You'll have to actually create a mission for them because they are not technical people. So we as clinicians, we know the importance. So we will have to come up with planning, create the entire project and present it to them. Like, for example, planning and stakeholder engagement. Okay, so here is A to Z of planning and stakeholder engagement broadly. I know we are short of time, so I'll just take you through the headings, subheadings. So you define objectives, you form a core team, that includes representatives from not just Tata Steel, healthcare providers, NGOs, local authorities, schools, appoint a dedicated project manager, collaborate with stakeholders, hospitals, ambulances, etc., and conduct a feasibility study, which all are the areas which would benefit the most. What is the logistics? What is the costing, etc. Right? So first step is planning. Now, we have already identified these locations, but management is going to say that why should I install it in the mall or multiplex? What am I going to do by installing in private schools, for example? It's private. It will not be calculated as a CSR activity. So we need to segregate these into categories. So public spaces, parks, stadiums, railway stations, bus stands. Yes, these are public places. Whatever a corporate does in these would go as CSR activity. They can do it for Tata-owned companies. It is not as a CSR activity, but as their own employee benefit initiatives. And they can do it for marginalized and poor people. But for remaining people, private entities, and affordable communities, they need not spend money, but they can at least educate these guys, educate school authorities that it is an important thing. So we are doing it across rest of Jamshedpur. You do it in your schools. So this is something that CSR can do. Secondly, second phase starts as awareness campaign. So A to Z of awareness campaign, large public awareness campaigns, use social media, newspapers, use community engagement, organize workshop in schools, colleges, conduct hands-only CPR trainings, engage influential influencers and leaders, like for example, celebrities, local influencers, etc. Third is actual installation of AEDs, right? So procure AEDs. For that, you may need to collaborate with AED manufacturers for bulk discounts or donations. Then install AEDs strategically, railway stations, markets, stadiums, etc. Ensuring proper signages, visibility should be there. Set up AED monitoring. Monitoring is very important. So develop a centralized system to track AED maintenance and readiness. Assign responsibility to local volunteers or organizations for periodic checks. Training and capacity building. So conduct CPR and AED training programs once again. Incorporate training in schools. Build up CPR programs in school curriculum itself. And rewards and recognition is equally important for corporates. So you recognize and reward heart-safe champions once in a while. And use of technology. You create an app, include all AED locations in Jamshedpur in that app, include all emergency contact numbers, integrate AEDs with emergency services, collaborate with 108 ambulance services. So many things which we individually cannot do, but company through their CSR can do it. And finally, it is monitoring, evaluation, and sustainability. The entire thing should be sustainable. So set measurable goals, keep a track of those goals, where we have reached. Ensure that financial sustainability is there. So secure separate funds for it. Encourage public-private partnerships for maintenance. Conduct periodic reviews and celebrate milestones. Like for example, Heart Safe Jamshedpur Day, just to increase awareness. So these are the things, so many things which corporates can do. And once we show that it's not only installation of AEDs, but all these things which you can showcase in your CSR report, there is a very high probability that CSR companies would accept it as a CSR project. And finally, liaising with the government. Like I said, all these companies have got a big clout with the government, and they can definitely influence public health policies, and they can encourage government to bring AEDs and CPR training as a public health initiative. So friends, to summarize, corporates can indeed play a big role in AED installations. However, there are genuine challenges that need to be overcome. There is a need for right packaging, package it as a mission rather than as asset allocation. Corporates alone cannot do it. Involvement of multiple stakeholders, uh, government, of course, NGOs, other well-to-do people in the society, all of them have to come together. There is a big role of clinicians. Corporates will not know anything about CPR. They will not know anything about AEDs. So we have to be the bridge and to play the role and help them define policies, and need to sensitize the government to make it a public health initiative. So friends, just don't think about it. Write it down today and make it happen. Let me end by a great quote by one of our greatest leaders, who calls upon collective responsibility rather than individual responsibility for betterment of the country. And I would like to acknowledge all these great people: Vice President Tata Steel, Chief of CSR, Head Public Health, and of course ChatGPT and Meta AI, from whom I've used regenerative images. Thank you, and regards from Tata Main Hospital.
Thanks, Mandar. Very, very impressive. And actually, I must say, I'm dumbfounded by your research into how to make this presentation and how to set a plan for CPR. It's phenomenal what you're talking. I hope we can realize a lot of it in the coming decades, maybe certainly by 2047, when we are looking to be a developed nation. Maybe this is a part of that developed program. Let me give it to Dr. J.C. Mohan. He has seen a world of cardiology, from putting the patient in the bed for 15 days to treat a MI to what Mandar is talking. Your impressions, Professor Mohan, on this? You are a Delhiite and close to the seat of power. What ideas could you generate from Dr. Shah's talk?
So, Dr. Shah, phenomenal talk.
Thank you, sir.
To be honest, eye-opening for me, and of course thought-provoking. It actually forced me to think a lot about it. This is something, when I was young, I tried to actually talk to a lot of people in Delhi government, including our health minister, who was a doctor himself. And this goes back to 1996, when I was at the helms of this Cardiological Society of India Delhi branch. Now that is nearly 30 years old story. Couldn't make any headway. But that was a time when CSR was not really a big thing, in fact. Maybe today we can do it. The city actually, with regard to AED, I think would be worse than Jamshedpur. I'm pretty sure of that. We have at the airport, I know we have at the airport, but nowhere else I have seen an AED in Delhi. Nowhere else. I also have to say one thing, which is of great importance. I looked at most of the large diagnostic centers of Delhi, who do stress echo, stress thallium, TMT. 90% of them don't have a defibrillator. 90% don't have. Yes. So when my son wanted to start a setup, I said, the first thing you have to buy is a defibrillator. He said, this is a waste of money. I have looked at all the centers. Nobody has it. Why do you want me to buy it? I said, if I am going to fund it, the first thing is buy a defibrillator. And buy a defibrillator on every step. So you are on ground floor, you are on basement, 2 different defibrillators. Don't keep them moving. So I was able to make this thing, but I have to say that we need to do a lot about it. And I had lost my mojo. I thought my days are gone, and I tried hard actually to convince the health minister and others, and nothing happened there. But I think we can reinvigorate this whole thing, try to get AEDs at multiple places. I can even think of actually involve. I think the Mumbai guy are doing a great job. I think Yash Lokhandwala, Ashish, phenomenal job they are doing actually. But in Delhi, we have no such initiative. Somebody has to do it. Somebody has to take care of it.
Sure. I mean, you said it, charity starts at home, and you did try to do something despite losing the mojo. I think there are people listening to it. Mandar, wonderful. I mean, as I said, you have laid out a plan of how to talk to the corporates, and there are different people that need to be talked in different way and persuaded in different ways to have it. As Dr. Mohan outlined, I think in Mumbai there is this revival. It's not restricted to Mumbai per se, but as I said, Mandar is a part of this. Dr. Aditya Kapoor from Lucknow is a part of this. And there is an attempt made to expand this circle of at least teaching. And this group in Mumbai is particularly active in terms of taking it to the railways, to the police stations, and things like that. So, but all that seems a drop in ocean eventually when you are not back at the governmental level, because the reach of the government is far too more than what we as individuals, even as small societies, can do. But I mean, you can't wait for there has to be a certain threshold of work reached when you can convince the local bodies or the local municipalities or the local state governments or eventually the government of India or whatever. But I think in a small way it is initiated. Dr. Mandar, anything more that you wanted to, which you did not put formally in your slides?
No, nothing specific as such, but there are challenges. So, like initially when I went to these people, no, so I was very disheartened. They gave me a very negative this thinking why it cannot be done. So then
I
I said,
can see it from the process that you say showed from the first slide to the last slide. It has moved through a thought process of learning to talk with the corporate. There is a lesson at every step as to how to go about it. So sure, please go ahead.
so exactly. But then eventually, when I said that no, we have to do it, you show me a way how to do it. So when things did not move at lower level, then I reached out to vice president and the chiefs, and they told me that this is how you should package. And then if you really think it is beneficial, we will definitely consider it. So I think for Jamshedpur, at least I'm at least going to make it a try to bring this as a mission.
Mandar, let's give this question to the Merck guys. I think Harshal or Vinita or you guys obviously doing this is not a CSR, arranging a CME like this. Uh, uh, but uh, this what would be your thoughts offhand? I mean, will not trap you into your thoughts, but at least how do you look at it as a CSR activity or whatever? What are your thoughts?
So definitely after listening to Dr. Mandar Shah sirs and the efforts he has put for a good cause, in fact, he has to put a lot of efforts. That's what we understood. Just to do a good thing, we have to put a lot of efforts. But it's a brilliant idea that it gave us a lot of motivation, and he has already chalked out a plan. I think it's already ready. The only thing, CSR activities are done by many corporates, and Merck is also one of the corporate who can think of supporting this good noble cause. So definitely, sir, we will take up this idea with our senior management to make them understand first what is it, and then probably the Mandar sir story will repeat here also again. But that's what it is in across India. I think it's an eye-opening session for us also, sir, at the same time.
Yeah,
But it's motivating also at the same time.
very, very eye-opening, Mandar, the process that you outlaid and really elaborately discussed. I mean, this is the language that, in this case, a corporate would understand as to why to get involved and things like that. Sure, I think we have had almost a good 2 hours of interesting session. Really, I'm happy to have been on a Sunday afternoon on this. The lunch is not delayed, so that's further Sone Pe Suhaga. But I think it was very interesting, and we really saved the best for the last. Let me thank Professor Mohan, a very, very esteemed faculty in all the meetings, to have found time and taught us about contemporary use of beta blockers, to Mandar, once again, CPR building skills at different levels, from organizing to teaching to whatnot. And I think we'll probably make a dent, at least among the attendees of this CME, and a little bit about arrhythmias in ACS. I hope I have been able to clear of some concepts. So, Harshal, are we, do you want to make some closing comments before we close this session?
Yes, sir. Yes, sir. Definitely. So we have actually registered doctors for all these events. 6 events is now 2,500. So it's a big numbers. Today we have more than 300 plus logins actually for this session. And this doesn't stop here, sir, because this
Yes.
recording goes on for in the bits and pieces also at the same time, and the whole recording also to all the registered doctors. So whenever they get time, they will definitely watch through all these important messages which are there. But it will be incomplete if I don't thank Dr. Ashish Nabar sir, Dr. JC Mohan sir, and Dr. Mandar Shah sir for their wonderful participation, moderation. And if I also apologize, Dr. JC Mohan sir, if any miscommunication from our end. But again, it was wonderful coming beta blockers coming from your end and across the spectrum. And we received the questions also. I put it forth to Dr.
Yes,
Nabar
couple of
sir.
them we have answered.
Yes,
Sure.
yes.
I think we'll
Yeah.
leave at that.
I'm sorry. I think the mistake must have been mine. I had been too preoccupied with a lot of
Yeah,
other things. I have not seen my email for a long time. And I just talked to somebody while I was walking to my car, and he said, "You just have to moderate." I said, "Okay, fine. There isn't anything I have to do." But normally I do a better job than this. Normally I do a better job than
No, you did a
this.
phenomenal job as it is, sir.
Yeah,
sir.
you
But I just add one thing. There are many comments to all of us, means all the faculties, that it's an excellent session. And to Dr. Ashish sir, few comments are like it's beyond doubt. So we don't have any doubts now in arrhythmia. So that kind of comments also came.
what
So
you
thank
should
you
do
so
is
much.
you should segregate Dr. Mandar Shah's talk and kind
Yes,
of, package it to the corporates and discuss it at your corporate level. Maybe something might happen at whatever level. But I think
sure.
it's a brilliant talk with a plan of going about it. So I think that has a wider repercussion. Anyway,
Yeah.
on this good note, I would like to thank Merck. I would thank our Secretary of the Indian Society of Electrocardiology, Dr. Ketan Mehta, as well as the president, Dr. Aditya Kapoor, and the advisor, Dr. S.B. Gupta. We are continuously on it to generate some useful learnings for the medical community, and hope this one also added to that. Thank you very much, Dr. Samohan. Thank you, Mandar, and thanks the Merck team. Thank you. Bye bye.
Thank you, everybody.
Thank you. Good day, sir. Bye.
Hello, everybody. I am Dr. Ashish Nabar, Treasurer of the Indian Society of Electrocardiology. As you know, Indian Society of Electrocardiology promotes a lot of ECG teaching and learning. As a part of this initiative, we have the CAD-A-THON program, a master class in ECG designed for ECG learning. This is an online program which will be conducted on 12th January, that's Sunday at 11 a.m. The program is going to be dealing with different aspects of coronary artery disease. I'll be the moderator and doing the first presentation, which is related to arrhythmias in acute coronary syndrome. Then we will have a presentation on the role of beta blockers in acute coronary syndrome, and this is by none other than Professor Dr. JC Mohan from New Delhi. I'm sure many of you have heard him before. It's a treat to listen to him